Okay, great. And Rima, if you want to move it just to the first, or this slide's great. So good morning, everyone. I'm Dr. Madeline Verhofstadt. I am the Chief of Medicine at St. Joseph Healthcare Hamilton, and we're delighted to welcome you all to our weekly medical grand rounds today. I'll go to the next slide, please. And so, as always, we do like to start with a land acknowledgement. We acknowledge that St. Joseph Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. Go on to the next slide, please. Wonderful. So it's my pleasure to welcome today Dr. Rima Shah, who will be presenting to us on a really fascinating topic, new and evolving area of glucose monitoring. And at this point, I'm going to hand things over to Dr. Meera Luthra, who is our head of service for endocrinology, and really pleased to have Dr. Luthra here. She's going to provide an intro for Dr. Shah before she starts her talk.
Thank you, Madeline. It's my pleasure to be here to introduce Rima. So Dr. Verhofstadt invited me, and it's a pleasure because Dr. Shah is a colleague in endocrinology at St. Joseph's. She's an assistant professor in the Department of Medicine Division of Endocrinology. She completed her medical school and internal medicine training at University of Toronto, and then she joined us here at McMaster for her endocrinology training. She also completed the clinician investigator program, as well as a master's in public health from Harvard University. Her clinical practice in general endocrinology, as well as diabetes, is based at St. Joe's. And I agree with Dr. Verhofstadt that this is a very exciting topic. We've had a lot of technological development in our field, and we look forward to hearing about it today.
Great. So thank you so much, Dr. Verhofstadt and Dr. Luthra. I'm very happy to be speaking at Grand Rounds this morning, and the topic of my presentation is going to be New Age of Glucose Monitoring. So before I start, I have no conflicts of interest to disclose. So in terms of objectives, my hope is by the end of the talk, you'll all be able to describe new glucose monitoring systems, understand the evidence for effectiveness of new glucose monitoring devices, and be able to integrate output from new glucose monitoring devices into clinical practice. So self-monitoring of blood glucose is a really important component of diabetes management, especially for those who are on insulin or other glucose-lowering medications that can cause hypoglycemia. Frequent monitoring allows for hypoglycemia avoidance and intervention, adjustment of insulin doses, especially rapid-acting mealtime insulin doses. It allows for dietary or physical activity modifications, therapeutic changes to achieve recommended glycemic targets, and increased empowerment and adherence to treatment. So blood glucose monitoring is what most of us are familiar with, and these traditional devices measure capillary blood glucose levels using a finger stick and a glucose meter. Many of the current meters that we have available now are reasonably accurate within a plus minus of 10% range of accuracy, and they require only a very small drop of blood. So continuous glucose monitoring devices, or CGMs, is what the bulk of my presentation is going to be on today. And instead of capillary blood glucose levels, they measure interstitial glucose levels, which usually correlate quite well with plasma glucose, but they may lag by about 10 or 15 minutes behind if the glucose levels are rising or falling rapidly. To compensate for this lag, most CGM systems will not only display what the glucose value is at a given time, but also a trend arrow that will show the direction of change. So either stable, an arrow going up if the sugars are rising, or an arrow pointing down if the sugars are dropping. There are basically three components to every CGM device. There is a sensor, which is right here, that accesses the interstitial fluid. It can be inserted subcutaneously by the patient and can be changed every 7 to 14 days, depending on the type of device you're using. Then there is a transmitter, which often sits right above the sensor and transmits readings electronically. And finally, the last component is a receiver, which is not shown in this diagram, but that can consist of a device-specific receiver, a smartphone, a smartwatch, or any other kind of smart device. And there are two main types of continuous glucose monitors. So the first is real-time CGM. And these measure, store, and transmit glucose values continuously and without any prompting every 5 minutes or so. All of the real-time CGM devices have alarms that will alert the wearer for hyperglycemia or hypoglycemia events. Some require calibration by using a finger stick to make sure the levels are calibrated before they can be used. Example of this that I've shown in my picture is what many of you may be familiar with here in Canada. This is the Dexcom G6 real-time CGM system. So this is kind of the device you use to insert the sensor. This is the transmitter, and this is the device-specific receiver, but a smartphone or smartwatch can also be used. Intermittently scanned CGM, or you may be familiar with the term flash glucose monitoring, is the second type of CGM. These systems will measure interstitial blood glucose levels continuously every minute or so, but they require scanning to transmit and store glucose values. Real-time glucose information on the last 8-hour trend is transmitted to the reader. And so the wearer really should be scanning the device about 3 times a day at approximately 8-hour intervals to capture a full 24-hour period of data. The earlier models of this system didn't have any alarms. Newer models do have alarms that are optional, so they can alarm for either hyper or hypoglycemia. There's typically no finger stick calibration needed for these systems. And the example that most of you are probably familiar with is the Freestyle Libre. So the Libre 1 is the older system. The Libre 2 is the newer system that has the alarms. So this slide here is from the Diabetes Canada guidelines, and it just outlines the definitions for the types of glucose monitoring systems that I've described. What I didn't mention is masked or professional glucose, continuous glucose monitoring. And this is really, done via a sensing device that stores data that is retrieved at another time. So it's not providing information at that time for people to act on right away. I won't be focusing that on this for this presentation. So in terms of reliability, I mentioned that for the most part, they correlate quite well to plasma. Interstitial blood glucose levels correlate quite well to plasma blood glucose levels, but there can be a lag if levels are falling or rising quite quickly. They tend to be less accurate at extremes, so very high or very low readings. There is some interference by substances, most notably acetaminophen or high-dose vitamin D may cause falsely elevated readings in some CGM devices. So that's important to keep in mind. So in terms of cost and convenience, real-time CGM systems are more expensive than the flash glucose monitoring systems. They will typically cost anywhere from $3,000 to $6,000 per year compared to $2,500 for the intermittently scanned CGMs. In terms of public funding, specifically for us in Ontario, the real-time CGM, Dexcom, what we're most familiar with, is funded publicly through the ODSP program or the NIH benefits program. Recently, the assistive devices program has opened up funding for the real-time CGM systems, but it's very specific criteria, and most of our patients would not meet those criteria unless they have a history of severe lows resulting in adverse effects. In terms of the flash glucose monitors, those tend to be more routinely covered. There is public funding through the Ontario Drug Benefit Program for those who are on insulin. So just in terms of some practical considerations in terms of comparing the two, just when we're seeing patients in our clinic, real-time CGM devices, often a limiting factor tends to be cost and coverage. The intermittently scanned CGM systems are covered through most plans and through ODB. There's no scanning required for real-time CGMs, whereas for the flash glucose monitoring systems, you need to scan at least 3 times a day, about 8 hours apart. All the real-time CGM systems have alarms. The newer intermittently scanned CGM systems have the option for alarms. The intermittently scanned CGM systems are more discreet. And so here is a picture of Kate Moss's daughter at the Met Gala. You can see her wearing her Freestyle Libre on the back of her arm, so quite discreet with her beautiful dress there. In terms of the evidence, there is much stronger evidence for real-time CGM data, and I'm going to be reviewing the evidence in more detail next. So first, I want to talk about the evidence for real-time CGM systems, and I'm going to do this for patients with type 1 diabetes, then type 2 diabetes, and then I'll focus on some of the evidence for the flash glucose monitoring systems, which is a little bit more limited when it comes to randomized control trial evidence, at least. So this is one of the original major studies that kind of established the effectiveness of CGM's continuous glucose monitoring systems, the real-time ones, in HbA lowering. So this was a study that was published in the New England Journal of Medicine in 2008. It was done in 332 adults and children with type 1 diabetes, and it compared real-time CGM devices to usual care with capillary blood glucose measurement. And the primary outcome was change in hemoglobin A1C at 26 weeks compared to baseline. Participants were stratified by age. So there was a group from 8 to 14 years, 14 to 24 years, and greater than 25 years. So you can see the results here. Overall, the results showed that there was a greatest benefit for improvements in A1C in adults over the age of 25, with an overall adjusted difference in mean change in hemoglobin A1C of minus 0.53%. So this scatter plot here shows the change in A1C. So on the x-axis, you see the A1C at baseline. On the y-axis is the A1C at 26 weeks. Basically, points that fall beneath or below the diagonal line shows cases that had improvement in HbA1c levels from baseline. So the black dots represent those in the interventional groups who were using real-time CGM, and the white dots represent those in the control group. And you can see there's more black dots under the diagonal line compared to white dots. This graph here similarly shows A1C at 26 weeks in the real-time CGM group compared to the control group. And you can see the gap showing that overall the A1C at 26 weeks was better in the real-time CGM group compared to the control group. So this is another study that was subsequent study that was more recent, the Diamond randomized control trial published in JAMA in 2017. it basically, so it included 158 adults over the age of 25 with type 1 diabetes. It compared the change in hemoglobin A1C at 24 weeks, and it basically confirms the findings that I showed in the first study. You can see the scatter plots and this graph look almost identical, and the adjusted difference in mean hemoglobin A1C change was minus 0.6%. The study further highlighted that the time in a target range of 70 to 80 milligrams per deciliter, which is equivalent to 3.9, a blood sugar of 3.9 to 10, improved by about 77 minutes per day in the real-time CGM group compared to the control group. And also there was decreased time spent in hypoglycemia overall. So on average, 43 minutes in the real-time CGM group compared to 80 minutes per day in the control group. So this study was done here to further look more specifically at hypoglycemia. It was done in 141 adults with type 1 diabetes who had impaired hypoglycemia awareness, as well as a history of a severe hypoglycemic event in the year before. These graphs compare the rates of hypoglycemia, so basically the number of hypoglycemic events in the last 28 days at baseline, which is a circle, compared to follow-up, which is an X. This is the data from the control group, which essentially shows no difference in baseline compared to follow-up. However, in the real-time CGM group, you can see there is an improvement in hypoglycemia events with the reduction of about 72% in hypoglycemia events in this group. So, this evidence can also be extended to patients with type 1 diabetes who are on insulin pump therapies. In this study, this was a multi-center RCT with a crossover design in which patients were either randomized to a sensor on, sensor off strategy versus a sensor off first and then sensor on strategy. Each period occurred for about 6 months with a 4-month washout period. And as you can see in this graph, those, with the sensor on at a given time had a lower A1C, and the mean difference was minus 0.43%. So this was an extension of the second RCT I showed you, and it was basically done to assess quality of life. They looked at 5 different measurements of quality of life, and they found that there was improved hypoglycemia confidence, as well as a modest decrease in diabetes distress scores in patients who are using the real-time CGM device compared to usual care with capillary blood glucose monitoring. So now I'm going to review the data in type 2 diabetes. There are fewer RCTs that have been done in type 2 diabetes. This study looked at the effect of real-time CGM compared to usual care in patients with type 2 diabetes who were using multiple daily injections of insulin to manage their type 2 diabetes. And so the primary outcome in the study was change in hemoglobin A1C at 12 weeks and 24 weeks. Overall, there was an improvement in the adjusted difference in mean change in A1C of about minus 0.3% at both 12 weeks and 24 weeks. So this study is interesting because it evaluated the difference in hemoglobin A1C over an 8-month difference between the intervention group that used real-time CGM and the control group, which was usual care. But it was in patients with type 2 diabetes who were just using basal insulin. It included 175 adults, and it showed that the mean hemoglobin A1C level decreased from 9.1% at baseline to 8% at 8 months in the real-time CGM group. And the adjusted difference between treatment groups was minus 0.4%. Again, here the scatter plot shows the A1C level at baseline. Here's the A1C level at 8 months. The dots below the diagonal line represent improvements in A1C over the 8-month period. Orange is the real-time CGM group. Blue is the usual care control group. And you can see there are more orange dots below the diagonal line. Similarly, A1C at 8 months was better in the real-time CGM group compared to the control group. So to summarize the evidence for real-time CGM, multiple randomized control trials have been done. I haven't shown you all of them this morning. Generally, the results have been quite positive, showing improvements in hemoglobin A1C and time spent in the target range of usually 3.9 to 10 millimoles for the blood glucose levels. I'm going to discuss that in more detail later on in my presentation. In type 1 diabetes, it's also been shown to reduce hypoglycemia and severe hypoglycemia and improve quality of life. The same effect on hypoglycemia has not been consistently demonstrated in type 2 diabetes. So now I'm going to review some of the evidence for intermittently scanned or flash glucose monitoring devices. The data is more limited with fewer randomized controlled trials done in this area. It's also important to note that most of these studies have also been done with the older versions of the intermittently scanned CGMs, which do not have the alarms. So in this first randomized control trial, it was 328 patients with type 1 diabetes, and it compared the flash glucose monitoring, use of the flash glucose monitoring device to capillary blood glucose monitoring. And the primary outcome here was a change in time spent in hypoglycemia over a 6-month period. Generally, the patients had a good glycemic control to start with, and one of the inclusion criteria was A1C of less than 7.5%. So it did show improvements in time spent in hypoglycemia with about a 38% reduction, and the adjusted difference of change in mean time in hypoglycemia was minus 1.24 hours per day. And the same study also showed, so it didn't show any changes in hemoglobin A1C levels at 6 months. This was not the primary outcome. And as I said, most of the participants already had pretty good glycemic control to begin with. But the time in range of glucose between 3.9 and 10 was significantly increased in the intervention group compared to the control group by an hour, likely corresponding to the improvements in time in hypoglycemia. So this is a randomized controlled trial done in patients with type 2 diabetes, 224 adults that were either on prandial or MDI insulin regimens. They were randomized to either the intermittently scanned CGM or usual capillary blood glucose monitoring. The primary outcome was a difference in A1C levels at 6 months, and they didn't see a change in their primary outcome. They did find there was reduced time in hypoglycemia and greater treatment satisfaction with improvements in the diabetes treatment satisfaction questionnaire among those who were using the intermittently scanned CGM compared to the control group. So to summarize the data of intermittently scanned CGM overall, results have been mixed. No consistent improvement seen in hemoglobin A1C in patients with type 1 or type 2 diabetes, really, on insulin, from RCT data at least. There has been improvements in A1C levels seen in observational studies that I didn't show here. There may be an improvement in the time spent in target range, which is the blood sugar of 3.9 to 10. Studies have shown decreased time in hypoglycemia, and some have also shown improvements in treatment satisfaction. So I want to, briefly just show you some studies comparing the two modalities. So comparing real-time CGM use versus the intermittently scanned CGM devices. There have been 3 randomized control trials done in patients with type 1 diabetes. The most recent one that's also the largest of the 3 with the longest follow-up period is the ALERT one, and these patients were followed for about 6 months. Primary outcome was the mean between group difference in time and range, and there was a greater time in range. Again, that's 3.9 to 10 with the real-time CGM compared to the intermittently scanned CGM. There was an improvement in A1C seen, as well as a reduced time in hypoglycemia seen. So just to summarize the evidence overall, several limitations, there are more RCTs kind of for real-time CGM devices compared to the newer intermittently scanned CGM devices, but all of the studies are quite small, 100 to 300-ish participants. Most of them have quite a short duration of follow-up. There's no kind of outcomes data on complications necessarily, with the exception of hypoglycemia. There's likely quite a bit of selection bias in terms of types of patients, that are in these trials that are generally quite motivated. The main thing is for these comparison studies, especially, many of them don't account for the differences required in calibration between the two modalities, or accuracy of the different systems, particularly at, for example, lower glucose values. And the intermittently scanned CGM studies may be less applicable now as the newer models have alarms, and this is maybe thought to be a key component in preventing hypoglycemia. But I think on balance, the evidence suggests, use of CGM devices results in, improved glycemic control, decreased hypoglycemia, and improved treatment satisfaction with CGM devices. So I'm going to spend the next half of my talk reviewing some of the data that comes from the CGM devices and how we can interpret it. So hemoglobin A1C has kind of been the key surrogate marker for assessing glycemic control and predicting complications of diabetes. It's also been the primary endpoint in many CGM studies, but it also has many limitations. So it only really provides an average glucose, over a 2 or 3 month time frame. It doesn't detect hypoglycemia or hyperglycemia on a daily basis. And so it doesn't really give you much information about the inter and intraday variability of blood glucose measurements. It's unreliable in many situations, like, in patients with anemia and those with hemoglobinopathies, in iron deficiency, for example. It doesn't reflect rapid changes in daily glucose control. And finally, doesn't really provide much information on how to adjust treatment regimen if someone comes back and has a high A1C level. You can kind of see from this visual here, I've tried to illustrate, 2 possible patients' glucose profiles, one in yellow, one in orange. And, if you're seeing these patients in your clinic, they may actually end up having very similar A1Cs, but you can see that the person in yellow kind of has more severe excursions and spends more time kind of in the higher and lower range than the orange. And A1C wouldn't necessarily give you that data. So, although A1C remains an important, marker for, risk factor for complications, It's not always helpful for personalized diabetes management, and it can be used in addition to some of and it should be used in addition to some of the data that comes from the CGM. So in 2019, the Advanced Technologies and Treatment for Diabetes Congress selected 10 metrics from CGM data that they felt to be the most useful for clinical practice. And these are shown on the right. So this is the number of days the CGM device is worn, the percentage of time the CGM device is active, mean glucose management indicator, glycemic variability, which is as a percent coefficient of variation, time above range, so usually greater than 13.9, time above range, which is above 10, but below 13.9, time in range, which is that 3.9 to 10, time below range, which can be divided into 3 to 3.8 or less than 3. And many of these metrics can be used to create standardized reports with both quantitative as well as qualitative or visual data that can really help you put things together. And I'm going to discuss some of these in more detail. So the first is sensor usage. So some measures of adequacy of data include the number of days the sensor is worn, usually 14 days is recommended, as well as the percentage of time the CGM is active, and greater than 70% is recommended. So if you recall, the flash glucose monitoring systems require scanning to be done at least every 8 hours in order to allow for that data to get recorded. If it's not scanned every 8 hours, then the data can be lost. Successful use of CGM is not just dependent on wearing the, it's really dependent on adherence. And so output data from these devices, studies have shown that it correlates well with 3-month measures of glycemic control if a device is used for 14 days and more than 70% of time active during those 14 days. So with this kind of optimal sampling, the mean glucose, the time in range, and the hyperglycemia metrics are well correlated with 3-month values. The hypoglycemia metrics and the glycemic variability do not correlate as well. So maybe for those, a longer time of data would be needed. So the big one that I want to spend some time talking about is the time in range. So this can include, the time in target range, the time above target, the time below target as well. And there's basically, 2 components of the time in range output. There is the individualized target range itself, as well as the percentage of time that should be spent in that individualized target range. So for example, in most people with type 1 and type 2 diabetes, the target range is suggested to be 3.9 to 10. This in pregnancy, the targets are a little bit more stringent, and those are sugars between 3.5 to 7.8. For most people with type 1 and type 2 diabetes, it's felt that more than 70% of time should be in that target range of 3.9 to 10. And same with pregnancy, more than 70% of time spent in the 3.5 to 7.8 range. In older patients or those kind of at more high risk, the target range is still the same, sort of not 3.9 to 10, but the time spent in this range can be a bit lower. And the key part of that would mostly be to try and minimize the time spent in hypoglycemia. So this chart here is from that advanced technologies and treatments for diabetes consensus, and it just highlights kind of some of the information that I just gave. So time in range has been shown to correlate strongly with hemoglobin A1C, with a goal of a time in range of 70%, aligning with a hemoglobin A1C of about close to about 7% in 2 prospective studies, and they're shown here. So on the left, this compared data from 4 RCTs in patients with type 1 diabetes. And again, it found that time in range of 70% correlated to an A1C of 7%. And this was kind of similar in the study on the right-hand side, which analyzed data from 18 RCTs and essentially found the same thing. So in this, on the left side, every 10% increase in time in range was about a 0.5% A1C reduction. And on the right-hand side, every 10% increase in time in range corresponded to about a 0.8% A1C reduction. So there have been some studies evaluating the association between time in range and diabetes complications. This was a study from 2019, and it evaluated the association with time in range with development or progression of diabetic retinopathy, as well as development of microalbuminuria, and they used data from the DCCT data set to validate and use the time in range as an outcome measure for clinical trials. And their analysis showed that basically the hazard rate for retinopathy progression, so retinopathy is shown on the left here, increased by 64% for every 10% reduction in time in range. Similarly for microalbuminuria, for every 10% reduction in time in range, the hazard rate for microalbuminuria increased by 40%. So for, again, similar associations between diabetic retinopathy and time in range seen in patients with type 2 diabetes. This was a large study of more than 3,000 patients with type 2 diabetes. And the graph plots the prevalence of diabetic retinopathy as a function of the time in range quartile, with the darker colors showing greater time in range. And so basically it shows that the prevalence of diabetic retinopathy decreased with increasing time in range. So the estimated GMI is kind of an estimate of expected A1C based on the glucose data. It's derived using a regression equation of laboratory A1C on CGM mean glucose, and it's primarily coming from individuals with type 1 diabetes. It's important to note that this should be differentiated from the laboratory measured A1C. It can be higher, lower, or it may correspond well. So the last thing I want to spend the talk doing is just reviewing a sample AGP report, and then looking at kind of the things to look for in this report. So this is a sample ambulatory glucose profile report from someone who's using the Freestyle Libre. And typically when I'm looking at these reports, there's 5 things that I look at. So the first is the adequacy of data. And so this you can look at here to see sort of how many days the sensor was worn, and the percent of time the sensor was active. So remember, you want hoping for as close to 14 days as possible and greater than 70%. Then you're looking at kind of the time in range, and that's shown in this green by this green here, which is time in with sugars between 3.9 and 10. Next thing is the frequency of hypoglycemia. So that's shown in red here, and they kind of break it down to 3 to 3.9 and then less than 3. Then I look at this, this part of the AGP curve, and first thing you want to look at is the shape of the median curve. So, does it look like there are, so the median is kind of this blue area here. And are there kind of steep ups and steep downs, showing kind of big spikes, or is it kind of more moderate up and downs? And that kind of shows you what the variability in a given day is like. And then the width of the IQR is the other thing to look at, and how wide it is versus how narrow, and that kind of gives you between days what the variability is like. So to conclude my presentation, new CGM devices include real-time CGM and intermittently scanned CGM devices. Studies have shown benefit for CGM over CBG for improvements, in hemoglobin A1C and time in range, reduced hypoglycemia, and often improvements in quality of life or treatment satisfaction. The output from the CGM data includes several metrics that will assess the adequacy of data, the time in range, time below range, time above range, the glucose management index, and finally the ambulatory glucose profile curve that allows us to offer kind of more personalized guidance for our patients with diabetes. So I'm going to end there and open it up to questions. Thank you.
Thank you very much, Dr. Shah, for an excellent overview of that really fascinating area. I can see that we've had a number of people joining and taking in the presentation. And to start off with, we do have one question in the Q&A. I've got some questions too, and probably more will trickle in. This is a question from Dr. Ann Holbrook, and I'll read it out to you. Overall, hypoglycemia is not the same as severe hypoglycemia requiring rescue, so it is a surrogate outcome. What is the current evidence on the correlation between overall hypoglycemia and adverse clinical outcomes, especially for type 2 diabetes?
So I guess in terms of current, so yeah, I mean, I think it's an important outcome. I think patients who have hypoglycemia, like even if it's maybe a surrogate outcome, it does lead to significant quality of life issues as well. And so often patients tend to be quite anxious about being in hypoglycemia, or are quite fearful of developing hypoglycemia, and that can result in kind of that can impact certainly their glycemic control. So I think, and certainly in terms of quality of life, that plays a factor. So yeah, I think that's what I'd say about that. I don't know if Dr. Luthra has anything else to add about that.
Yeah, so I think it would be a different study, right? Because I'm not sure I fully understand the question, but I think the CGM studies, as you said, are looking at frequency of hypoglycemia and looking at a reduction in hypoglycemia, probably from alerts and alarms and awareness that people can treat. So we have arrows down, and if the Dexcom has a feature called urgent low soon, which will predict with a pretty 80% accuracy that you're going to have a low blood sugar in the next 20 to 30 minutes based on your current glucose and the trend. And so averting that low is beneficial, and that's how it would reduce hypoglycemia. Whether it reduces clinically significant severe hypoglycemia, I don't know that they've looked at that, but we do know that frequency of hypoglycemia is predictive of more severe episodes because you tend to lose the awareness. And so to that extent, if we're reducing hypoglycemia period, and particularly lows below 3, which is thought to be more severe, not severe in the clinical judgment type of, but in terms of degree of hypoglycemia, I think that we do have that data. So less than 3 and between 3 and 3.9 are two separate categories usually in these studies on CGM, and the predictability is helpful.
Great, thank you so much. So another question from Dr. Ann Holbrook. Is there an explanation for the interference of acetaminophen and vitamin D with readings? Seems like an odd combination, not really pharmacologically related. So interesting
It's
question.
not vitamin D, it's vitamin C. And I believe it has to do with interference in the enzymatic reaction, or how that those levels are actually detected. I know the acetaminophen is more of an issue for the real-time CGM devices over the flash glucose monitoring devices, but the vitamin C, I think, can impact both. Acetaminophen use, its effect on affecting values is dose dependent. In terms of the exact, interference on the assay, that I'm not sure about.
Okay. Great, thank you so much for that. So it's just those two medications or supplements?
Yeah, and some of like the Libre one, ASA has been thought to maybe cause some interference as well, but it's mostly just those are the two main ones.
Okay, very interesting. We have another question here from Dr. Sandra Ofori. Thanks for an excellent talk. Do we have any data for the reliability of CGM in the peri-op period compared to usual finger stick / blood glucose monitoring, given that it's monitoring interstitial fluid glucose?
That's a great question. Not that I came across as I was, preparing this talk. Yeah, I don't think they've specifically looked at values in the peri-op period. Like I said, I think the interstitial fluid in general is pretty well correlated with plasma glucose levels. Again, it's really just those, rapid rises and falls where it can lag a little bit, but I think, overall it shouldn't tend to, I can't see it, being much more different in people in the peri-op period compared to those who are, not in that time.
It seems like maybe it could be a really great research question. And I know Dr. Ofori and her group do a lot of work in perioperative medicine. So, that could in fact be a clinical setting where having continuous glucose monitoring would be particularly useful. Might be my hypothesis, but I'm not the expert. Dr. Luthras got her hand up, and then I notice as well that your colleague, Dr. Braga, has her hand up. So Mira, go ahead, and then we'll invite Dr. Braga to chime in.
Yeah, actually, I think Dr. Braga is saying the same thing I was going to add is that the Dexcom G6, which is the latest version of our CGM that we're pretty consistently using now, is not affected by acetaminophen any longer. So that's great. They've overcome that problem, as Tylenol, as you can imagine, is quite ubiquitously used by patients. So it's no longer an issue. And with regards to the peri-op, I agree with you. I think it would be a really good, interesting question. We've certainly launched this sort of initiative or encouraged the use of our insulin pumps in the perioperative bariatric setting at St. Joe's. And the only thing, and some of them, as you know, are linked to sensors as well. So it would be very helpful to know that there's validity and accuracy. The only one issue I can think of is sometimes with sensors, there's this pressure phenomenon where the readings will, it'll stop reading and you'll get an error because you're like when people sleep on their belly and the sensors on their tummy, for example. So we would need, the anesthesiologist would need to be aware of the positioning of the patient with respect to the location of the sensor. So they wouldn't be able to, anytime you have pooling or a lot of compression, then you end up not reading, and that would be a problem because then you wouldn't be getting data. Something to think about in the patient who's under anesthesia.
Some special considerations in that setting. Thank you so much. And so then we next have a question from, it looks like Dr. Braga has chimed in on the chat and via Mira. So we've got next a question from Dr. Richard Zizzo. Is there evidence to use CGM intermittently, say 14 continuous days out of a 90-day period in selected patients and gain meaningful meaningful data?
Absolutely. And I think, that's where the studies have looked at this 14-day period, comparing it to data obtained from a 3-month period. And basically in the studies, they were looking at, data obtained from a 3-month period, and then kind of on a daily basis, the, correlation coefficient from kind of sequential days over that time. And the highest correlation coefficient was for certain measures only. So I think you can definitely get meaningful data on the mean glucose, time in range, and the hyperglycemia, so the time above range metrics, they tend to correlate much better. And so I think it's, you can get definitely meaningful data based on that. That has the best evidence, I guess I should say. I think you can still get, meaningful data from that snapshot. I think it's been suggested maybe, a 4-week period to get more, correlated information about the low events and things like that, because the hypoglycemia indices were not as well correlated from a 14-day period compared to the data that comes from 3 months, but perhaps like a 4-week period as opposed to a 2-week period would offer, more of that correlation. But I think you can still get quite meaningful data. And often we will kind of put our patients on, continuous glucose monitors for a short time frame, to give us that kind of data.
Excellent, thank you. I have a question which is maybe a bit more broad, which is more related to can you give us a sense of what is the diabetes population that you and your endocrinology colleagues based at St. Joe's are looking after? And maybe of those patients with type 1 diabetes, do you have a sense of what the overall proportion of patients who are using some form of glucose monitoring?
A really good question.
Today? Yeah,
I would say, I mean, I haven't, calculated myself, but I would say most of my type 1 patients are using some kind of CGM, especially now that, with the Libre, there's coverage through ODB and through most, insurance providers. I would probably say more than 50%. I don't know what, Dr. Braga and Dr. Luthra say, but I would definitely say more than 50% of type 1s. And it tends to be more of the flash rather than the real time, simply because of, cost and coverage issues. Yeah.
Mm-hmm. Would you see that if cost and coverage issues weren't a barrier, would you see this being closer to 90 to 100% of patients who would be interested and potentially benefit based on your assessment?
I think so. Yeah. I mean, I think some people, who don't want it, but I think for the most part, that might improve uptake for sure.
Mm-hmm. Mm-hmm. Yeah. Very, very interesting. I think we're reached the end of any questions that are coming through. Is there anything else that you wanted to add, Dr. Shah, or you, Dr. Luthra, even just related to your clinic program as an overview for the folks who are in attendance today?
I don't really have anything else to add.
No problem.
I'll just mention that actually during COVID, we had some compassionate coverage provided by Libre, the intermittent scan CGM, for use in hospitalized patients. And so our nurses had put that proposal through, and as medical director, I had to sort of sign off on it. But it was helpful to have that data in patients in, for example, the nephrology side of things and on transplant, and they do a lot of inpatient diabetes, and we can really also extend the use of these devices potentially to help us with our inpatients as we get more evidence and data in terms of that minimal interaction, going into the room every time to do a finger poke during COVID precautions. That was very helpful. And certainly also just getting trends while people are being initiated on insulin, which often happens in hospital if they're a new diagnosis of type 1 with DKA or type 2 starting on insulin. And so, again, we would need to have the burden of proof to support that sort of cost. And I'm not suggesting that we're going to P&T now to get this done, but I think it's certainly something for the future to think about for our colleagues who work in the hospital, that there are studies being done. There's definitely discussions at our meetings from, people in the States. And so I think it's coming. We just have to sort of keep an eye out for, what exactly does it add and how much benefit. But in the COVID setting, certainly it was a helpful short-term relief for the nurses to have that data and not have to go in 4 times a day to get these readings, especially on type 1s who are admitted to hospital with quite a bit of variability in their sugars.
Yeah. Thank you so much. And possibly on that same topic, one more question has popped in here. Can the device be shared after sterilization with change in sensor?
So, once the sensor is out, it can't really be reinserted. So I would say no.
Mm-hmm. From what would be an ideal device to use in hospital, something that could have some longevity and could be used for a few days for one patient and then moved on to another patient rather than it being disposed of, that would definitely be an important consideration. Might be a little bit of a dreaming scenario from the sounds of it, but that's great. Well, thank you so much, Dr. Shah, for a phenomenal overview of a really interesting and topic that continues to evolve. I think if you had asked anybody here 5 years ago or 10 years ago, like this would have felt like science fiction. So this is really exciting. And I, for one, I'm really excited to see where we're at 5 or 10 years from now. And it looks like you're going to be on the leading edge of that. I'd like to again thank Dr. Luthra for joining today to introduce and co-host, and wish you all a fabulous day and week. We'll be back next Thursday morning at the same time, and we will have GIM rounds. I believe we have a visiting speaker next week. More details to be coming out in the next couple of days. So thanks.
Thank you.
Thank you.